Okay, so hopefully this is why I wanted to do everything with you guys first. Hopefully all of this should sound like stuff you already know. And then we'll maybe do one more little small lecture and then we'll be done for today. Okay, while I'm thinking about it, your ATI stuff, I know y'all got caught up in studying for the final and everything. As long as I'm gonna give you all the way through this week. And I'm going to collect it on the 30th, which is the day of your first test for IV therapy. And I'll go ahead and pick it up then. And then y'all can do, make sure you're doing practice B independently. And then I'll let you know for sure the date of the proctored ATI exam. But I want to just make sure that y'all can just turn it into me in person. Or you can email it to me, whatever you prefer, to get your points for that. It'll probably be easier in person because most of them were, those active learning templates were handwritten. So, okay, so basic equipment for IV therapy and then the supplies that you need. So those are just some more key terms. Those are all going to be throughout this whole time. I'm going to keep referring to them. So if you don't know them or you don't hear me discussing them as we go along, then you can go back and look those up. I do want to say that most of our systems, I have not worked with a non-needleless system. So whenever y'all were practicing, they have that little alligator clamp that goes into to connect some of the piggybacks. That's kind of old school, using a needle to do all that stuff. Ours are needleless and they're going to lure lock into one another, okay? And they should be compatible at the place that you work. All right, so usually this is an example of a rigid or semi-rigid open container. Most of our containers do not look like this. For IV therapy, they look like this, which is what you guys practiced with. The principle is the same. You're just ensuring not to touch when you are inserting your spike. You're just ensuring not to touch the insert, the area at which you're inserting or your spike. You're maintaining asepsis when you're doing that. All right, over here. Can y'all see my little mouse squiggling, or can y'all just see the slide? Y'all can't see. You can't see what I'm pointing to. All right, so we're just gonna start at the top left. That extender is gonna come in the bag with your IV, with your secondary piggyback. That's that little blue thing that comes in that other kit. That's gonna make the primary bag lower than your secondary bag. So that's what that is. The injection port, that second port of your bag, that's not the blue part that let me go back to this one. Not the blue part that you're pulling off of here, but this port right here to the left, that is the port that's used to inject medication into this bag. So if your bag is coming with 20 milliequivalents of potassium with normal saline, they're using that to inject it. Generally, pharmacy does all of this mixing, but if they just sent you a separate vial of Ansef and said that it needed to go in 500 milliliters in 100 milliliters of normal saline, then you would just inject it through this port right here. Generally, you do not have to do that. That's why it's important to read on your bag, read what your label says, and it'll say, 500 milligrams of Ansef in 100 milliliters of normal saline. And remember, your milliliters is your volume. So if it's asking volume to be infused, that will always be your milliliters of the bag as a whole. We talked a little bit in class. You'll have some of at that injection port, a lot of your medications will be hanging there and you'll have to pop it and squirt the medication into a little chamber and mix those medications, but it'll already be pre-attached. So just ensure that you're using the right port to connect your spike. You have your sterile spike right here that you're not to touch at all. You have your drip chamber, which you're going to be watching to make sure that your drops are coming out correctly. You have your back check valve, which is that little extra piece that ensures that stuff from your line is not going back into your bag. You have your port at the top, which is where your secondary tubing is going to connect. You have your slider clamp, and then you have your roller clamp. You have another port down here, and then this is your extension tubing from your IV that's screwed onto the end of your line. So all of that should look pretty familiar to you guys, right? Nothing looks foreign on here. So your normal drips, your tubing, remember I told you, you're never going to have to determine how many drops per milliliter that's not something for you to determine. Your tubing determines how many drips per milliliter are administered. So normal drips per milliliter are going to be 10 to 20. Macro is going to be 10 to 20, and then your micro are going to be 60. So macro drips are going to be used for most things, like normal saline, all of your regular solutions. Micro drip would be used for something that we didn't want delivered over a long period of, we didn't want delivered too quickly. So like if your patient was getting something with potassium, then we would use micro drip, because we would ensure, even, remember I showed you guys, even if you open it wide open, it still only comes out at a certain rate. It's not pouring into your patient's vein, whereas macro drip would. The control clamp is going to be the way that you determine how quickly things are coming out of your line. When you're setting up your pump, you always want to make sure that your control clamp is closed, and get everything all set up, and then open your clamp so that you're not dripping solution everywhere. This is just another picture. Y'all know where to set up, where to hook your piggyback to at the top here. And it will be two separate programmings on your pump. You'll have a primary line and you'll have a secondary line that you will be infusing. Sometimes stopcocks are used, but not very often. I showed y'all what this looks like. This is your stat lock. This is your PICC line. You know that your IV tubing screws directly into these, just like it would your extension tubing on your, your regular peripheral IV. And the clamps are, a peripheral IV has a clamp as well. So when they're not in use at all, we want to make sure that that clamp is clamped. When they're in use, we want to make sure that it's unclamped. That's one of the main reasons that your IVs are going to beep, is usually you forgot to unclamp something or your patient is kinking your line. Those are going to be your two main reasons that it's, that it's fussing. And then y'all see the route of a PICC line. When your patient has a PICC line, there's usually a sign posted above the bed. And if that sign is not posted above the bed, it should be in the front of their chart. But best practice is to have it above their bed, so you know that it is in fact a PICC line. You cannot do a blood pressure in the arm in which your patient has a PICC line. And something I failed to mention previously, when you are starting your IV, you need to make sure that your patient does not have a limb alert, make sure you need to ask them directly, is there any reason that I cannot stick you in either arm? And if they say, yes, I had a mastectomy, I can't be stuck on the right side, then they need to have a band on that arm that says limb alert. There needs to be something to indicate that they don't need to be stuck on that side, but you also need to make it practice to verbally ask them in case they forgot to tell somebody, or that band isn't there, or they took it off, or whatever. You always need to ask. Now, we wouldn't put a limb alert if they just don't prefer for that side to be used. If they're just right-handed and they really don't like to be stuck on their right side, we would take that into account and we would avoid it, per their request. But we wouldn't necessarily put a limb alert because they don't have a medical reason not to be, to be stuck on that side. So if it came down to an emergency event and we had to have an IV, we could use that side. So limb alerts are, specifically used for your patients who we do not want them to be stuck on that side, under any circumstance. We've looked at our IV. So this is a butterfly. It is used to draw blood. It cannot be used for IVs because it doesn't have a catheter inside of it. It's just the needle, like I showed you guys in lab when I was showing y'all how you draw blood. It's very similar to those other collection containers that I used, but it is not sufficient for IVs. So that's a butterfly needle. This is your IV catheter. They have different brand names. I usually call them Gelcos because that's the brand that I use whenever we first started, but there's a whole lot of different brands to use. These are your sizes for this particular company. Most companies I have seen stick with these colors. 18s are green, 20s are pink, 22s are blue, and 24s are yellow. It could deviate from this, but it's gotten pretty consistent over time, for them to use these colors to be universally, where if you're going to grab a 22, then they're blue. I haven't really seen them deviate much from those colors. This I had already discussed with you guys earlier. We're not going to use, so let's see. I'm trying to see something. I would prefer for you guys, rather than this IV fluids, I would prefer for you guys to refer to that page that I told you in your book. Remember I told y'all earlier, on page 662, preferred solutions. All right, so hypertonic solutions replace electrolytes. They should be given slowly to monitor for circulatory overload. Lactated solutions or lactated ringers are solutions that are isotonic and used for rehydration and body fluid deficits. They don't contain sufficient potassium or calcium to replace losses. So they're just keeping that homeostasis. They're not giving back anything that was lost in regards to electrolytes, okay? Not enough to replace, I should say. It's enough to keep it maintained. Or y'all, does that make sense when I tell you we're not replacing? We would have to add potassium or add magnesium to replace. These are just keeping that, they're maintaining. We always want to check the medications for compatibility prior to administering. So nearly all, I don't want to say all for sure, but nearly all things are compatible with normal saline, which is your 0.9% saline. With lactated ringers, you need to check your drug book to see if your patient has LR going as their primary fluid. You need to make sure that your medications are compatible with lactated ringers. If they are not compatible, then we would disconnect, we flush with 10 cc's, give the medication, flush with 10 more cc's. We would not want them to mix in the line, okay? If they're compatible and you need to give a push, you would be able to kink your line of saline, cleanse, give the medication, and then let your medication run back through, because essentially it's being flushed with your other medication. But as far as just practice goes, it's always safer practice to assume stuff is not compatible. And it doesn't take 2 extra seconds to flush, you know, and assume that they're not compatible. So IV pushes are given by syringe at the IV port. You know that. It gives a rapid dose of medication over 2 to 5 minutes. When I was showing y'all how to dilute these medications, diluting them is not necessarily always necessary, but it does always ensure that you can push it slow enough to meet those recommendations of 2 minutes. So like if you're drawing up a half of milliliter of Lasix, let's just say, when you're pushing it, you just have to push a teensy bit to ensure that you're giving it over 2 minutes. When it's diluted with 10 of normal saline, you can push, you know, 2 milliliters every 30 seconds and be within your range. So there's not necessarily a right or wrong way to do that, as long as you are ensuring that you're giving it over the recommended time frame. Book nowadays on the computer for your when you're giving your medications, those little Lippincott things, you can just do a quick drop down and it'll tell you. IV piggybacks, you know, are intermittent infusions that use a secondary line. IV medications injected into a volume chamber or diluted with a running IV fluid. Don't worry about that. Electronic IV pumps precisely measure the flow rate and regulate that flow rate over a period of time. So tell me this, how will you always calculate your medications if you're using an electronic pump? How will you, what 2 things will you need to calculate?
The infusion rate?
The infusion rate. How's it going to come out? Drops per minute or milliliters per hour?
Drops.
No, milliliters per hour. For a pump, you'll always be in mils per hour. If you're counting it by hand, which we often do not do, that's when we're going to know drops per minute. We are going to count them drops per minute. If you were using a pump, it's always going to be in milliliters per hour. What is the second thing that you must know if you're using a pump? It's going to ask you for it.
The amount to be infused.
The amount to be infused, or the VTBI, the volume to be infused. Those are the things that you're going to need to know. All right. And then you'll need a sterile gauze dressing. We don't use those very much because we cannot see that site. If we put a gauze over the insertion site of the IV, then we cannot monitor it. We can't with confidence say no redness or swelling at site because we can't see our insertion site, right? So we want to use a transparent dressing or a Tegaderm so that we can visualize our IV insertion site. And then we always want to secure it with tape. That's it for that one. That might be it. Let me see what other things I have real quick.